this presentation. So we will discuss about the spinal trauma. But to know about the spinal trauma, the anatomy of the spine and spinal cord is very important. So that will also be discussed. Then we will present about the causes of spinal injury. We will also discuss that how these patients present, and when we receive a patient with spinal injury, then what type of investigation should be advised for such patients. So when we diagnose a patient with spinal injury, then what will be the treatment of that patient? And at the end, I will again, just for the to know whether we know about the spinal injury or not. So for assessment, I will again discuss a few slides. So that will just to know about the revision what we have learned during this presentation. Anatomy very important. If you don't know about the anatomy of the spine and spinal cord, then we cannot have any full knowledge about the spinal injury. If we look at this diagram, this shows the spinal column, that is the cervical region. We have 7 vertebrae. This one is thoracic, slightly curved and kyphotic shape, and that is the lumbar region, lordotic shape, and sacrum and coccyx. So this is the whole spine column, and these are the individual vertebral bodies at different level. So this is the vertebral body of the cervical region. So for the vertebral body to know, there are different parts of the vertebral body. If you look at this portion, that is the vertebral body, but this one is the lamina of this vertebra, and that is the spinous process. These are the facets, and this canal foramen is the foramina transversarum, and through this foramen the vertebral artery is passing. This is very important, that is called spinal canal, and that is present in all vertebral bodies, and through this the spinal cord is passing. The cervical vertebra, which is having long spinous process like this one, if you compare the spinous process of this vertebra with this one, so this is long one, that is the C7. The thoracic vertebrae, they are slightly different from the cervical and lumbar vertebrae. If you look at this one, that is the spinous process. These are the laminae. This is the facet joint, and this is the transverse process. And that is the spinal canal, which is passing through the spinal cord, which is passing through the spinal canal, and these are the nerve roots which are coming out through the intervertebral foramina. This is the individual vertebra of the thoracic region, and we are that is the lateral view of this vertebra. This is the vertebral body, anterior border, superior end plate, inferior end plate. These are the joints of the ribs with this vertebrae. That is the superior articular process. This one is the pedicular area, and this is the spinous process. And this is the axial view, that is the canal. This one is the pedicle, this is the vertebral body, this one is the lamina, this is the transverse process, and this is the spinous process. This slide is showing the different vertebral bodies, that is the cervical region, lumbar, and thoracic, dorsal and thoracic is same. And again, as I mentioned, so I have discussed the cervical and thoracic in detail, but this one is the lumbar. The main difference of the cervical is that they have a canal for the foramina for the vertebral artery, that is called foramina transversarum or vertebral artery foramen. In case of lumbar vertebra, the vertebral body is larger as compared to other vertebrae. But here, if you compare this one with the thoracic one, so in the thoracic, the spinous process is angulated more downward, while in lumbar it is slightly transverse. This is the pedicle, and here over the pedicle, these are the joints. So here the rib head is attached, while here the angle of the rib is attached to transverse process. So the transverse process of the thoracic vertebra is slightly angulated, while this is transverse in case of thoracic lumbar vertebra. So this is the transverse process of the thoracic, while this is the transverse process of the lumbar vertebra, and you see that this is slightly different and long as compared to that of the lumbar. The spinal canal is present in all of them, and through this canal the spinal cord is passing. As I mentioned and discussed in the early slides, the spinal cord is passing through the spinal canal, and this is the spinal cord, which has a central portion which contains the cell bodies, and that is the gray matter. And in the surrounding area, anteriorly, laterally, and posteriorly, the different tracts ascending and descending are passing, and this is the white matter. From the spinal cord, the different roots coming out are entering, and they form the spinal nerves. So the spinal cord, the main tissue of the spinal cord, has outer layer the pia mater, and then the arachnoid, and outer one is the dura mater. So the dura is covering all these structures, and that is more clear here. So this one is the spinal cord, gray matter. This one is the white matter, and these are the uh, dorsal roots. These are the ventral roots, and there is ganglion in the dorsal root, and that is called dorsal root ganglia. And both the dorsal and the ventral roots, they form the spinal nerve. These are the vertebral. These are the different blood vessels. These red one are the arteries which are supplying blood to the spinal cord, and the blue one are the veins which are taking blood from the spinal cord. And the spinal cord is surrounded by the pia mater, arachnoid mater, and dura mater. And the spinal dura is different from the dura of the brain, in that the spinal dura is single layered, while in case of brain there are two layers of the dura mater. So that is somewhat difference. And again, that is more clear. You see that this is the vertebra of the cervical region. This is the vertebral body, foramen of transverse cilium for the vertebral artery. This is the facet area, this is the lamina, and that is the spinous process. And there is the canal, that is the spinal canal, and the spinal cord is passing through this. You see this one. And again, white matter and gray matter, and the roots are coming, and they form the spinal nerves. And you see that the spinal cord is this one, which is surrounding by the pia, arachnoid, and the dural layers. And I'm repeating this thing again and again so that we may know. And this is the dorsal roots, ventral root, and forming the spinal nerves. And again, this is a magnified and clear view of the spinal cord. White matter, gray matter, central canal. This is the anterior portion. The posterior portion is known by this ganglia, which is from the dorsal roots. These are the ventral roots, these are the motor roots, and these are the sensor roots. And this is the sulcus, anterior spinal sulcus, through the anterior spinal arteries passing, while there are two posterior spinal arteries, which we'll discuss in the coming slides. These are the different tracts, ascending tracts and descending. So the descending tracts, which are starting from the cortex and different structures inside the brain, in the lower part of the medulla, they are crossing, which is called decussation, and then entering into the spinal cord, and from there the second order neuron starts, and that goes toward the tissues. So the descending tracts, corticospinal, and then from the spinal cord towards the muscles or joints or different parts of the body, and these are the ascending. So the first neuron that starts from this tissue toward the spinal cord, from the spinal cord towards the thalamus, and from thalamus towards the sensory areas. So some of the fibers are crossing like that for pain and temperature, while those fibers which are for vibration, they are coming in the dorsal spine, and they are not crossing the spinal cord. And the station is in the thalamus, and from the thalamus another nerve starts. So ascending tracts which are going towards the brain for sensation have three components. First nerve is from the tissue toward the spinal cord, from the spinal cord toward the thalamus, and from the thalamus to the cortex. While descending tracts are two, from the cortex to the spinal cord, and from the spinal cord to the tissues. Blood supply, to know about the blood supply is very, very important. These are the arteries, which are small branches then coming from the different artery like from the aorta and the vertebral arteries. They form the segmental vessels and then divide into anterior and posterior. So anteriorly we have a single artery, anterior spinal artery, and posteriorly we have two spinal arteries. And these are the arteries which are supplying the spinal cord. And these are the histopathological views of the spinal cord. This one is gray matter, this is the white matter. And whenever there is spinal injury or damage of the spinal cord, so then changes and ischemic changes occur in the spinal cord, which is a decrease in size, and there might be contusions, there might be ischemia, there might be hematoma, and that is damaging the different parts of the spinal cord, and then the patient can have presentation accordingly. The sensory level is very, very important. And if we want to localize a lesion, for that sensation and sensory level is very important. So if you don't know about the sensory level, then for us it will be very difficult that where is the lesion and what is the level of the spinal cord which is involved, because we know that there are different portion of the spinal cord, might be in the cervical, might be in thoracic, might be lumbar portion. So if we know about these sensory uh, divisions, then we can localize the lesion, whether the lesion is in the cervical or thoracic or lumbar region. So this is the anterior view, and you see that in the clavicular region, the C3 and C4 is sensation is there. On the shoulder, the sensation is that of C5. On the outer part of the arm, C6, while on the inner of the upper arm, there is T1, on the forearm, T2. The thumb is for C6, while the middle finger is for the C7 and little finger is for C8. So these are the areas to know about the sensory levels that can help us a lot. Sorry, presentation को बहुत हो जाती है. Then on the trunk and on the abdomen, so at the level of the umbilicus, that is T10, and at the level of the nipple, that is T4, and in the lower limbs, on the middle aspect of the leg, that is T4, on the lateral, that is L5, while in the posterior, that is S1, on the back toe is L5, while in the little finger of the foot, that is S1. So if the patient is having decreased sensation at these levels, then we can localize where is the pathology. And again, if you look at this one, that is more clear. So shoulder level is C5, C7 for middle finger, for thumb that is C6, for little finger and middle portion that is C8, forearm medial is T1, and arm medial is T2, while axilla up to axilla is T2. Below the clavicle T3, and above the clavicle the level is C3. So it is very, very important from neurosurgical point of view. So whenever we are examining the patient, if a patient is having decreased sensation up to the level of T10, so that shows that up at the level of umbilicus, so that shows that the T10 level is that of the spinal cord. If a patient is having decreased sensation on the middle finger, so that shows C7 nerve roots and C7 level. So sensory examination and to know about it is very important, to know where is the lesion. So this all discussion was about the anatomy, about the clinical picture and clinical skills of on these patients. Now to discuss about the spinal injuries, you should know that what are the causes of spinal injury. And if you look at this slide, the major causes might be road traffic accident. And in our country, road traffic accident is very common. So when patients come to us, so most of them have a history of road traffic accident. Then history of assault is also very common, especially in our country. And you see that when there is assault, the patient can have fracture of the vertebra. Firearm injury, very common, and history of fall. So if you look at this a patient, there is fall, and most probably this patient might have cervical injury because there is tilting of the head, and most probably there is damage of the supraclavicle region along with the cervical vertebrae and cervical levels. So these four major causes: road traffic accident, assault, firearm injury, and fall. Now, when a patient is having spinal injury, what will be his presentation or her presentation? So presentation depends upon where is the lesion. So if a patient is having trauma of the cervical, so you know that all the fibers, both the upper limb, lower limb, and spine sphincters, they are passing through. So if there is damage to the cervical vertebrae, there will be underlying cord injury, and the patient can have weakness in all four limbs. If a patient is having injury at this level, so the upper limb are spared, so there will be weakness of the lower limbs and sphincters, and at this level again the lower limbs. And you know that spinal cord ends at the lower vertebral, lower level of L1 vertebra or upper border of L2. So if there is injury below the L2 vertebra, so there will be only roots involvement, and the patient will have not complete spinal injury, but the patient will have lower motor neuron injury, and that will be discussed in the next coming slides. So whenever we are taking history of such patients, we should ask about these things. One is history of trauma, whether there is history of road traffic accidents, there is history of fall or assault or firearm injury or any other cause. And then we should ask about the spine limb sphincters. The patient is having pain in cervical, lumbar, thoracic. So spine, limb, these three things are very important. And then look for the limbs, whether the patient is having weakness of the upper limb and lower limb both, or only lower limbs. And always do not be confined to these things, but we should have also systemic review. So ask about the systemic question as well. So when we are taking history, then after that we are going to examine the patient, and again look for these three important things: spine, limb, sphincters, and then systemic examination. So if there is tenderness of the cervical spine and the patient is not able to move all four limbs, so it shows that the injury is the cervical region. If a patient is having tenderness and pain in the thoracic region, and he is having weakness of the lower limbs but the upper limbs are intact, so lesion is here. If a patient is having pain in the lumbar region and there are only sensory involvement but the motor is intact, so it means that the lesion is below the L2. So again, as I mentioned in this presentation slide, we should not be confined only to the spine. So when a patient is having injury, history of trauma, and there is spinal injury, so always look for the systemic examination as well. This patient can have head injury, they can have chest trauma, they can have abdominal injury. So the patient should be examined as a whole from head to toe to know any other associated injuries. And you know that this diagram shows, so cervical, there is weakness of all four limbs, and the patient is having sensory and motor deficit below that level. In the thoracic region, so the upper limbs are spared, and this area, this blue area, that shows involvement, and in the lumbar sacral is below, so the patient is intact here. These are the ascending and descending tests, as I mentioned. So this is the motor portion, that is the dorsal spinal cord, which is showing involvement, and that is where the vibration and for the position sense. Well, these are the tracts for pain and temperature, and these are the ascending, these are the descending tracts, which is showing the motor portion. So these surrounding are the sensory portion, and this is the motor portion. So when a patient is having spinal injury, the injury can be complete or incomplete. There may be involvement of the anterior portion of the spinal cord or posterior part of the spinal cord, or right or left portion. or there might be roots involvement or spinal cord involvement. So on the basis of clinical examination, if we have taken proper history, we have examined the patient properly, both for motor and sensory deficits, then we can localize the level of the injury as well as the extent of involvement of the spinal cord. So if you look at this slide, the whole spinal cord is damaged. So when the whole spinal cord is damaged, it means that both the motor and sensory fibers will be involved. Both the pen temperature and dorsal spine is involved. Both the ascending and descending tracts are involved. So this patient will have no motor power below the level and there will be no sensation. So that is called complete spinal injury. Well, in this slide, this spinal cord of this area, that is one half is spare while this is damaged. So if this half is damaged, what will happen to this patient? These are the motor fibers. So on this side, on the right side, there will be motor deficit. And if you think, if you know that the pain and temperature, they are cross when they reach, the fibers cross when they reach the spinal cord. So if this portion is involved, so the pain and temperature coming from the opposite side of the body, that will be involved. So in this patient, there will be weakness of the right side, but pain and temperature will be gone on the left side. And as I have discussed in the previous slides, the fibers which are that for the position sense, for the uh, vibration, they are not crossing. So this patient will have decrease. This will have involvement of the position sense and vibration on the same side. So this is called hemical syndrome or Brown-Séquard syndrome. So when this half of the spinal cord is involved, there is involvement. There is involvement of the motor portion of the right. There will be right side motor deficit. Pain and temperature will be involved on the left side, while position sensation will be involved on the right side. So that is called Brown-Séquard syndrome. If posterior cord is involved, so the posterior cord contains only the dorsal column, and the dorsal column is for the position and vibration. So if there is infarction or involvement or damage of the posterior portion of the cord, in this patient, the power will be intact, the pain and temperature will be intact. Only the dorsal column involvement will lead to involvement of the position sense and that the vibration and the fibers which are passing through this one. And when there is anterior cord involvement, so the anterior total of the cord involvement, there is motor deficit as well as pain and temperature. So if a patient is having intact dorsal column, intact sensation of vibration and position, but there is no temperature sensation, no pain sensation, and there is weakness, so it means that the dorsal column is spared and the anterior column is involved. But if a patient is having only involvement of the vibration and position, but pain and temperature are intact, the patient is having normal power, so it means only the dorsal column is involved. So clinically one can localize. And again, as I mentioned, that the spinal cord ends at the lower border of the L1 vertebra. So if there is damage above the L1, there will be cord injury. But if there is damage below the L1, there will be roots injury. So in roots injury, there will be only sensory involvement, while here there will be motor involvement. But sometimes at the junction, this is called conus. So when the conus is involved, there will be mixed type of sensory and motor deficit. So here cord injury, here roots injury, and here mix. So one can localize clinically where is the lesion and which portion of the spinal cord is involved, where conus level, where the lower cardiac vana, which is not spinal cord but the spinal roots, or whether cervical or whether it is in the thoracic region, the right cord, the hemicord is involved, or the dorsal column or the ventral column or the whole column is cord is involved. So clinically we can localize and we can reach to the level. So when we have taken history from a patient with spinal injury, we have examined the patient, then we should investigate this patient to know exactly about the level, about the extent of involvement of the spinal cord, about the extent of fracture of the vertebral body. So for this, we should all, and for any other injuries in addition to a spinal injury, so we should go for investigation. And I always divide my investigation into three: baseline, specific, and relevant. Baseline means urea, creatinine, blood CP, electrolytes, all these things. Specifically in the spinal injury, we go for X-rays, CT scan, and MR. Mainly MRI and CT scan. So MRI tells us about the spinal cord injury, and CT scan and X-ray tell us about the vertebral bone injury. And for relevant means, if a patient is having chest injury, we should go for X-ray chest or CT scan of the chest. If the patient is having abdominal injury, we are going for ultrasound abdomen. If the patient is having head injury, we are going for CT scan of the brain and head. If a patient is diabetic, hypertensive, or having cardiac disease, so we also investigate this patient accordingly. So always divide these into these three: baseline, specific, and relevant. So when a patient is investigated, then what should be done? So these patients should be treated, and the treatment or in managing this patient, first of all, before taking history examination, we should follow the basic rules of ATLS, that is ABCDE: airway, breathing, circulation, uh, to know examination of the patient as a whole, and for any deficit. So these patients should be examined from head to toe, and to know about any deficit to expose this properly so that no injury might be missed. Counseling very important. So if a patient is having spinal injury, we should counsel the patient as well as the family whether the patient might have recovery or not, what should be the treatment, what they should know about their injury, and what can be the outcome, and what you will do with them. So counseling means that the patient should know about the disease, about the pathology, about his spinal injury, what further damage can be done if the patient is not treated. So this patient might need treatment, and what will be the benefit of the treatment, what can be the complication of the treatment, and what will be the outcome. And when the patient is willing or the family is willing, then you can start the treatment. So generally we put these patients on painkillers, muscle relaxants, as well as steroids sometimes, but that is controversial. And when the patient is stable, then we go for surgery. And the surgery, some patients need surgery while some are managed conservatively, and again that depends upon the extent of involvement of the spine and spinal cord. So always we divide surgery into two: one is conventional surgery and one is recent advances. So in case of conventional surgery, we go for fixation, while in recent advances, again there are many advances in these interventions which I will mention. And whenever these patients are operated, so always they need post-op care, and post-operatively we take care of the wounds. We and there are can be different complications like C-syphilic, or the patient can have hematoma, or there may be further deficit. So this patient should be examined and that should be monitored for these things. And when the patient is stable, that sent home, and then we ask him to come to our outdoor, that is OPD, for follow-up. So when we receive this patient, we go for clinical examination. We take history, we examine this patient, and if need, we go for X-rays, MR, or CT scan. That depends upon the condition. Rehabilitation is very important in spinal injury. So one is physical rehabilitation, one is psychosocial, and one is professional. So this slide shows an overall uh, outline for the management of any disease. So whenever you are asked about management, so that started from ABCD: counseling, general treatment, medication, surgery, post-op care, follow-up, rehabilitation. So treatment protocol is this one. If you follow this one, you will not miss even a single thing and your treatment will be proper. Now, what are the principle of spinal injury treatment? So we reduce the spine, we decompress the spinal cord, and to maintain the reduce and decompression, for that we go for fixation and immobilization. So these are the basic principles which we follow for the treatment and management of outpatient with spinal injuries. To know about the spinal injury and its management, this three-column theory is very important. So by three-column theory means that the spinal column are divided into three portions. One is the anterior column, and that is containing the anterior half of the vertebral body, anterior half of the disc, and anterior longitudinal ligament of the column. Then the middle column is the posterior half of the vertebral body, posterior half of the intervertebral disc, and the posterior longitudinal ligament. And the posterior column contains spinous process, the different ligament, the facet joint, the laminae, the pedicle. So the importance of these three columns is that if there is involvement of two columns, two or more than two, so that shows that the spine is unstable and that patient needs surgery. Suppose uh, if this patient is having involvement of the anterior as well as posterior column, both are damaged, so this is unstable and surgery should be done. Or if there is involvement of the posterior column and middle column, both are damaged, this patient needs surgery. Even and if all three columns are uh, damaged, again the patient is unstable, the spine is unstable, and that patient needs stabilization. And for stabilization, we go for surgery. And I will discuss all these surgeries in detail in the coming slides. This is an illustration, and if you look at this slide, this is cervical region, and how can we identify cervical? So in case of cervical, the first vertebra C1 is very small, that cannot be identified easily, so we start counting from C2. And in case of C2, cervical vertebra 2, up to here is vertebral body, and then there is the odontine process. So when we are looking to this vertebral body from the lateral side, so a long bony structure is seen, that is C2. So from here we start counting. And this one is the spinal canal. The spinal cord is lying there. These are the posterior portion, that is the spinous process. And if you see at C5, 6, there is injury of the spine leading to compression of the spinal cord, and that is seen on X-ray like this. So this is C2 vertebral body, C3, C4, C5, and C6. And at the level of C5, 6, there is subluxation. So when a patient is having lesion at cervical, he will be complaining of pain in the cervical region, and there might be weakness of all four limbs. So if a patient is having weakness of all four limbs and there is pain in the neck, so most probably he is having cervical injury, and for that we are going for CT scan, MRI, and X-rays. So X-ray will be like this one. This is the MR of this patient, and if you look at this one, these are the vertebral bodies. This black grayish, this is spinal cord, and this is injury. C2, 3, 4, 5, 6 slip injury, and that is compressing the spinal cord. So this white one in the spinal cord is contusion and edema, and this is compression and angulation of the spinal cord, and that is seen like this on the CT scan. So CT scan tell us about the vertebral body like this, and this long one is C2, C3, 4, 5. So CT scan tell us about the bony anatomy, while spinal cord anatomy is seen best by the MRI. So we should go for CT scan and MRI both in case of spinal injuries. So what will be the presentation of this patient? This patient can have weakness in all four limbs, and there will be pain in the cervical region, and there might be involvement of the fiber which are for the sphincter. So there will be, and as I mentioned, we should concentrate on three things: spine, limb, sphincters. So in the case of spine, this patient will complain of pain in the cervical region. There will be, in case of limbs, there will be weakness in all four limbs, and there might be involvement of the sphincter, so there might be urinary retention and incontinence. Again, this illustration in MRI shows This is spinal cord, and there is damage of the spinal cord at this level. This is MRI, disc prolapse, that is leading to damage of the spinal cord. So what should be done? And after taking proper history, properly examine this patient, and further all investigation, then we go for surgical intervention. As treatment is started after counseling, medications. So what we do, we open this region from anterior side. We reach to the spinal level. We remove the portion of the vertebra and the disc which is compressed in the spinal cord. So the spinal cord is freed, and then the space which is formed here, we put a graft of bone or cage here to maintain it in its proper position. Then we go for anterior plating. So whenever we are decompressing the spinal cord by removing vertebral body, the space is there. The space is filled with the graft, and to maintain the graft in its position, then we go for plating. Then again, in the craniovertebral junction, when there is injury, this is C2 vertebral body, and then what happens that we go for occipital-cervical fusion. In case of, if you look at this slide, so there is thoracic injury. There is fracture of the thoracic vertebra, and this fracture line is passing through the disc space as vertebra. So when there is fracture of the vertebra, there might be involvement of the spinal cord, which is passing through this area. And look at this one. This is L1 vertebrae, which is fractured, and that is compressing the spinal cord here. So if the lesion is at the lumbar or thoracic, the patient will present accordingly. So the patient will have pain in the particular region of the spine, and there might be involvement of the limbs, lower limbs, because the upper limb are spared, as this is the thoracic or lumbar region. And the weakness in the limbs, the lower limb, that will depend, that will be according to the extent of involvement of this spinal cord. And again, this is a X-ray, and that is CT scan, and there's fracture of this. And in lumbar, we start counting from the sacral region. So this is the sacral, and this is L5 vertebra, 4, L3, L2, L1. So this is L1 fracture. When there is fracture, and if you look at this one according to three-column theory, as I mentioned, in three-column theory, anterior half of the vertebral body, and middle column, posterior half of the vertebral body, and the third column or posterior column, the remaining portion. So if two columns are involved or damaged, that is unstable. If you look at this vertebra, both the anterior as well as posterior, both the anterior and middle columns are involved, and that is compressing this area, that is the spinal cord. The spinal cord will be damaged, and this is unstable. So if you look at this one, that is the MRI, and D12 vertebra is collapsed, that is compressing the spinal cord, and both the anterior and middle column are involved, and this is again unstable. So whenever there is unstable spine, that needs stabilization, and for that we go for surgery. In thoracic and lumbar, what we do, we go for transpedicular screws. So screws are inserted above and below in the normal vertebra, and then these are connected with the rods, and we also go for grafting on the both sides, just to stabilize the spine. And you see that the spinal cord is decompressed, as I mentioned. So the principle is immobilization, decompression, and reduction. So these are the things which should be followed. And when if you look at this one, the vertebral body which is compressing the cord, that has been removed, and the space which is here, graft can be put in the form of bony graft or in the form of cage. So whenever we put a graft, either in the cervical or thoracic or any region, so if we don't fix it, so there are chances that later on it can come out. So to maintain its position in its space, we go for plating or screw fixation over it, so that it may not move from its place. So again, this is the transpedicular screw, and the screws are passed through the pedicles in the vertebral body, and this is the damaged portion. So we go for reduction, then the spinal cord is decompressed, and to maintain it in its position, so that is fixed, and the particular region is immobilized. So what are the complications which can be in these patients? Because when a patient is having a spinal injury, So the patient can develop a lot of complications. So we can classify these complications according to the different systems which can be involved. So cranial complication, systemic complication, metabolic, and others. So cranially, the patient can be in depression. There can be a lot of psychiatric problems as a patient is lying on the bed, not moving. So the patient can have chest problem. The patient can have pneumonia. The patient can have cardiac problem in form of arrhythmias, hypertension or hypotension. In GI, the patient can have gastroenteritis. The patient can have gastric stress ulcers. The patient has catheterized, so he can have UTI. He can have stones later on in the kidneys. There might be metabolic changes, there might be bed sore, there can be DVT, there can be electrolyte imbalance. So this patient can have, when a patient is paralyzed and he's lying, he or she, they are lying on the bed, so that they can have a lot of complication and any system can be affected. So just as I mentioned that for assessment, we should review what we have learned. So if you look at this slide, so what is it showing? Start from here. This is the sacrum, L5, 4, 3, 2, 1. So there is L1 vertebral fracture. Both the anterior and middle column are involved. So when two columns are involved, that is unstable. And this vertebra is retropulsed posteriorly. So this is a canal, and the canal there is spinal cord. So it means that this might have damaged the cord. So again in the thoracic vertebra. So what should be done is it is unstable. So we should go for reduction. This portion of the spinal cord should be decompressed. This should be reduced, and then we should go for fixation. Again, in this patient, if you look at this is MRI and this CT scan. So this long one is C2. This long one is C2 vertebra. So we start counting from here: C2, C3, C4, C5. This black one is spinal cord, while this white one is C6. So there is pathology at this level compressing the cord. Look at this fracture of this level compressing the canal. So this patient is having involvement of the cord at the cervical region. So there will be three presentations: spine, limb, sphincters. There might be patient will complain of pain in this region. There will be weakness of all four limbs, and the patient can have sphincter involvement as there is compression of the cord. So first it should be decompressed. As the space is formed, so graft should be put in there. For that grafting to be maintained, we should go for plating. So when cord is compressed and the patient is having deficit, so those patients need surgical intervention to decompress the spinal cord and to stabilize the spine. So for stability, what we do, we go for grafting and plating. Again, if you look at this one, there is subluxation. This one is C2 vertebra. This one is spinal cord, and there is compression of the cord. And there is compression of the CVJ level, craniovertebral junction. So what we do, the spinal cord should be decompressed, and to maintain the stability of the spine, so this should be fixed. And again, if you look at this one, so we are starting from the sacrum, L5, L4, L3, L2, L1, and D12. So this vertebral body is involved. Both the anterior and middle columns are involved. So it is unstable. There is compression of the spinal cord, so the spinal cord should be decompressed. As the spine is unstable, so for stability, we either go for removal of the vertebral body with plating and grafting, or posteriorly with the transpedicular screws to make it strong. So at the end, I would say that spinal injury, a very important topic from neurosurgical point of view. So when there is injury of the spine, that is damaging the underlying spinal cord. So when the spinal cord is compressed, the patient will have weakness according to the particular level of spinal cord involvement. The patient can have presentation according to the level. So three things should be remembered: spine, limbs, sphincters. In spine, the patient can have pain, either the cervical, thoracic, or lumbar region, whichever is damaged. The patient can have weakness in the upper limb and lower limb, or only in the lower limb. So in the cervical region, both the upper and lower limb will be involved, while in the lumbar and thoracic, only the lower limb will be involved. And if the whole spinal cord is involved, then that can damage the sphincters, fibers for the sphincter, and the patient can have retention or incontinence. This patient should be examined from that point of view, like spine, limb, sphincters. But in addition to it, systemic examination should not be ignored. and investigation is baseline specific relevant. So specifically X-rays, MRI, and CT scan. MRI will tell us about the spinal pathology, while X-ray and CT scan will tell us about the bone, that is the vertebral bodies and vertebrae. Management is the same as I mentioned: counseling, medical treatment, surgery. So surgery is done only when the spine is unstable and the spinal cord is compressed. So for that, we go for decompression, we go for stability, and for that, fixation is needed. And always these patients are followed in OPD. So there can be clinical follow-up, there can be radiological follow-up, and these patient needs, they